for this very unusual yet very intriguing amalgamation of the Indian Orthopedic Association with Orthobiologics, which is being spearheaded by the ISCSG, which is the Indian Stem Cell Study Group Association. And we have both Dr. Manish Khanna, who just introduced us, and Dr. Alok Agrawal, who's going to take the lead. It is indeed the future of all forms of healthcare. And it's very often that we have patients who come to us and ask us about stem cells, ask us about growth factors. And it is something we ought to know. It's least invasive. It's something which we still are not sure of. But there is a lot that we still don't know, which we ought to know. And today we sit here on the threshold, wanting to realize where this infinite science of medicine is taking us. And this is probably the beginning of a very, very important here, spearheaded by Dr. Atul Srivastava, which will tell us the way forward. I am most honored and privileged here to be representing the IOA. And I do see my colleague, Dr. Atul Srivastava, who has joined intermittently and has probably lost contact. But till he joins, I would hand over the proceedings and wish well for this large academic gathering to actually take us forward to the land of the unknown. Thank you very much for inviting us, and over to you.
Thank you so much. Thank you so much, Dr. Chaddha, for encouraging wonderful words. Thank you so much. Now over to our own president, Professor Alok Agrawal, the president of Indian Stem Cell Study Group Association, for the welcome note. Professor Alok.
Dear friends, I welcome you to the Maiden Regenerative Orthopedics session. This activity is by the Orthobiologics Subcommittee of Indian Orthopedic Association. I welcome Professor Dr. Atul Srivastava, President, Indian Orthopedics Association. I welcome Dr. Chaddha, President-elect from the Indian Orthopedic Association.
Last 4 minutes.
I welcome Professor Dr. Manish Khanna, who is the member secretary for this activity of orthobiologics for this year. As you all know, this first module will be covering what is stem cells and what these can give in medical science. This session will also answer what and why are the growth factors and what is their role in orthopedics. So this will be a very interesting session, and I know each and everyone, not only us, but the people who are with us are going to benefit with this. Thank you again. Thank you.
Thank you so much, Professor Alok, for an encouraging note. Now we'll request Dr. Atul Srivastava, if he has joined. Sir, can you hear us? Yeah. Over to Dr. Atul Srivastava, our president.
Yeah. Sorry, Manish Bhai, for some hiccups with the connectivity.
No problem.
And wish you all a very happy and safe New Year. And what I feel is orthobiologics is the future. And it is high time that this be involved in the mainstream. And that is why we have the subcommittee of the Indian Orthopedic Association with the most competent people in the field who have contributed and devoted a lot of time on this. And Dr. Manish Khanna, Dr. Alok Agrawal, Dr. D.P. Bhushan, and Tanmoy Mohanty, sir. So I wish you all the best and take it forward. All the best.
Thank you so much. Thank you so much, Dr. Atul Srivastava. Thank you so much for the encouraging keynote for us. So with everybody permission, we're going to start the session now. Well, once again, a very warm good evening in this winter from North India. Well, great minds discuss ideas, we all know, and average mind discuss events, small mind discuss people. So I welcome every great mind here on this platform for discussing the idea, the future orthobiologics. When we were a student, we don't know this terminology of orthobiologics. Well, stem cells are receiving a great deal of scientific attention everywhere. And one of the main reasons for this is the ability to regenerate the various tissues, and this can be useful in various medical conditions. Regenerative science holds a positive future in the medical conditions, which usually faces a lot of challenges. And for us, it is orthopedics and orthopedics. Our body tissue, bones, soft tissues, joints, everywhere they harbor the stem cells, the progenitor cells. So we already are having the kits in our own body at all the places. And for us in the orthopedic, it is the tendons, it's the ligaments, it's the bone, periosteum, everywhere. The idea is to continuously repair and regenerate and to give best result to the patients. What and where are the clinical needs of the regenerative science and the medical practice? This we are going to see this evening. Stem cell applications are there right from every condition, like we are discussing orthopedics, but for all practical purposes, even in the strokes, in the pulmonary fibrosis, in the liver cirrhosis, the stem cell has got a role. Even the T cells have got a good role in the pancreatic cancers, autoimmune diseases, diabetes, rheumatoid arthritis. So many autoimmune diseases are there in the body, and everywhere the stem cell has got a role. A lot of clinical trials have been done across the globe. The neurodegenerative conditions for which the patients goes to the neurophysicians are again having a lot of boon for from this orthobiologics. That is the stem cells. So we are going to start the session from Professor Dr. Tanmoy Mohanty, who is Professor in Head from KIMS Bhubaneswar. What stem cells and what these cells can give to us. Over to Dr. Tanmoy Mohanty, sir. Professor Mohanty, please, you can share your screen.
Hello.
Yes, sir.
Can you hear me?
Yeah, we can hear you.
Can you see my screen now?
Not
No,
yet. मनीष जी आप स्टॉप शेयर करेंगे तो शायद उनको मिलेगा.
Is it? I think I have stopped sharing. Yeah, I have stopped it. Yeah. Yes, sir, we can see it.
मोहंती सर शुरू करिए, you're on.
Yeah.
Are you ready?
Yes, sir, we can see. You can make it a slideshow. Yeah, perfect, sir. Please go ahead. Thank you. Thank you.
So it was very nice to Dr. Khanna suggest about stem cells in medical science. This is the first webinar we are having on behalf of Indian Orthopedic Association. Basically, when you look at stem cells, we always think it is something very special, which is giving us something new. But about stem cells, people have studied it from the details from long time. Basically, we know a stem cell is a cell with unique ability to develop into specialized cell types in the body. In the future, they may be used to replace cells and the tissues that have been damaged or lost due to disease. Now, always we think when we get old, our cells will die, but we want to remain amar. For that reason, everybody wants how these cells will not die. So the only way is that we cannot stop a cell from dying, but we can replenish the cells by methods. And we see that these stem cells have the ability to go on dividing as much as necessary to at least replenish the loss of these cells in our body. So these stem cells finally can become a muscle cell, can be a fat cell, can be even a bone cell, and anything. Starting from the nervous cell to epithelial cell, they can be regenerating into that. So stem cells are different from other cells in the body because they can divide, they can renew themselves over a long time, but they are unspecialized because they cannot do specific functions in the body. Now we have got two varieties of stem cells. As you know, it is embryonic stem cells or adult stem cells. These embryonic cells initially are single cell embryo when we call it totipotent. Within 5 or 7 days after fertilization, the embryonic stem cells, they are called pluripotent, and at that moment we can play with that and change its direction where the lineage will occur. Now in a child or an adult, finally we get the adult stem cells, which are called multipotent. And these cord blood cells are in the placenta, which can be kept for future use, which are called multipotent. Now, induced pluripotent stem cells, what does it mean? That means in adult stem cells, we can take them and do some method by which they can be induced to change into other cells. It has been seen that umbilical cord cells can be kept. We call them as primitive stem cells. We can keep it when the child is born with permission from the child, interest on the family, because the child may require this type of cells in future. We can store the cord blood, and from that we can get the cell, and then these cells can be finally used to get some method of coming out with organs even. So with this, we always keep the cord banks and other things are coming up, and we see that immediately after the child is born, we can store some of this blood which would have been thrown like this, and that can be kept in a cord bank, and finally this cord blood bank will help us in future. So now these autologous stem cells can be later transplanted into the body in case the patient really needs in adulthood. With that interest, we can go into a little bit of how the stem cell works. The human embryonic stem cell normally is the embryonic cells. Normally, we try to take at a cellular level. That stem cells can be collected after 3-4 days of the fertilization. At that moment, by micropipette, you can remove the nucleus from that, and those nuclei can be kept. And finally, you can get some stem cells out of that. And these are human embryonic stem cells, which are the future of our work. These stem cells in vivo after fertilization, when the IVF is done, normally it has been seen 1 or 2 cells are used by the patient finally. But lot of thousands of frozen embryos are routinely destroyed when the couple finish their treatment. So these are the stem cells normally we get to do some work like research on them. And these surplus embryos would have been thrown like this, and regenerative medicine, medical research normally helps us because these pluripotent stem cells can be utilized finally to give us pancreas or a hemopoietic or blood cells. They can give us even heart cells, everything. So this is finally what our aim is, to restore the damaged tissue in the body when the person really needs it. Cloning came into the view when people think that you can take a mouse, even can make a small ear over that, and researchers in Japan, they could grow human ear on the back of a laboratory rat with stem cells. So people thought we can go for even cloning, and finally we can get a lot of things out of that. But what is the use in medical science? We find that the adult stem cells can be hemopoietic, can be mesenchymal stem cells, or they can be neural stem cells, or epithelial stem cells, even skin stem cells. These adults, from the bone marrow itself, we can take them, even we can modify that, and finally we can get liver cells, we can get CNS cells, we can get skeletal muscles. That is why this is the plasticity of the adult stem cells, which can be modified slowly, and a lot of research are being done on that. Even researchers have already shown that adult bone marrow can be guided to become heart-like cells, which can repair the heart tissue in people, and more research is ongoing now. Now, when we try to see it in medicine, how it is used. We see that the bone marrow can be removed, and then adult stem cells can be derived from that and can be utilized, or we can do a programming on that. Even we use virus for that, and finally these programming will give us induced pluripotent stem cells. Otherwise, in an embryonic condition, from the blastocyst itself, we can keep embryonic stem cells. Now, this adult cloning, when we are doing, finally what is our aim? We are taking the cell, maybe through a biopsy or anything, maybe from the adipose tissue, and that adult cell, we take out the nucleus out of that, and the nucleus from another donor is put into that. This nucleus, after when the cell divides, finally we can, immunologically compatible transplants can be made out of this. This is how we are thinking that finally we can use these stem cells in a better way, that which can be used for another person. So the potential uses of this, what we see, already Dr. Khanna told us that the drug discovery and other things also stem cell can be used, not only for the patient. Suppose we want to try a drug. Now we want to see its effect in liver. We can make a liver out of these stem cells, and on that we can try our drugs. Very simple. And also we can screen potential drugs by using it on. We need cancer cells, we can modify the cells into cancer cells. And then we try to test these drugs on that. So these type of things, normally we need pluripotent these cells, which are completely available to us at any time with research. Now also we can see that when we see that cells can be regenerated, we can replenish that in the brain, suppose for Alzheimer's, in the spinal cord for spinal cord injury. Even in a case of stroke, we can have some neural anatomy can be changed, or it can be replaced. Severe burns, when we need a lot of areas to be covered with skin, we can get skin grafts and covers. For heartbeat, for diabetes, where we lack insulin, we can even come out with some part of the pancreas. Even we can think of regeneration of the cartilage in the osteoarthritis knees. And sometimes in autoimmune disease also they have got a role to play. In short, I wanted to tell you that not only the stem cells can be used like that, we can even try to use gene therapy along with that. So the modern thing is that we can use gene therapy along with that. Suppose you take a sample of bone marrow, which is taken, and then the stem cells are isolated and then allowed to multiply in culture. Then the cells are treated with modified virus containing a therapeutic gene. This therapeutic gene really helps us in taking some changes in that. That means we have corrected it, and these corrected cells are injected into the bloodstream. When these corrected cells reach the site, they see that there is a damage. They try to repair the damage. Not only that, they start removing the damaged cells there, and in that they started multiplying, and this will finally lead to healthy tissue. In short, I wanted to tell you what we are planning in future. We are only planning to regenerate the area. That means this is a regenerative medicine which is taking up, and stem cell therapy, also known as regenerative medicine, because it promotes the repair response of the diseased. Dysfunctional or injured tissue can be there. We can use these stem cells and their derivatives. It is our next chapter in organ transplantation, because the uses cells instead of donor organs, which are limited in supply. And we have to be very careful, because it really takes up the ethical issues. Because of human embryonic stem cells are extracted from human embryos, several questions and issues have been raised about the ethics of embryonic stem cell research. Some countries even ban it, and the National Institute of Health created a guideline in 2009. So if you are really interested to work on this, or you want to study about the stem cells, you have to get into the guidelines and then plan out something. Thank you.
Thank you so much, Professor Mohanty, for wonderful, excellent presentation on what is stem cell, what are the clinical needs, what are the research things which we are going for it, and what is the use in the medical science. Thank you so much for excellent thing. And it is very much clear from this presentation that the homing principle has been mentioned by Professor Mohanty, that people ask that how the stem cell reach to suppose we are injecting a mesenchymal stem cell for a clinical trial in a rheumatoid arthritis patient, how they are going to reach to a particular joint or particular organ. So it is just like the same thing. If you are having a sore throat and you are taking an antibiotic, it reaches to the particular site which is required. So thank you so much. Now let me continue this. So definitely, as been expressed by Professor Mohanty, it needs a lot of input, a lot of thought to carry this forward, this research. Definitely, people like Nancy Reagan, he has suggested that stem cell has got a lot of hope. It may provide a lot of answers to the scientists who are longing it for a very long time. If the potential stem cell research is realized, it would mean an end of suffering to the million of people. Mentioned by Michael Fogg that if stem cell research succeed, there is not a person in a country or across the globe who is not going to benefit from this. Well, this history starts actually speaking from 1998, the time when probably, I was completing my MS Orthopadics. So researchers first extract the stem cells from the human embryos. In 1999, first successful human transplant of insulin-making cells was being done. 2001, when the President Bush restricted the federal funding, and that was a vacuum actually at that time, which was being released again in 2002. 2002 is the main part in which the California OK stem cell research. It's still the hub of the research who are going on in the globe at the California. 2004 was the year when the Harvard research grows stem cells from the embryos using the private funding, for which the 2004 again approximately 3 billion bonds was being invested for the stem cell research. And finally, the ban was lifted in 2009 when the federal funding was available by President Obama. In 2014, we started as a Indian Stem Cell Study Group Trust with Indian Orthopedic Rheumatology Association, an orthopedic regenerative group, because we play with the bone marrow. We, our professors used to tell, and we used to do at the same time when we are not aware about the union, then we are taking out the bone marrow, injecting at a particular site. If we are having some hiccups with the union process and the patient has come for a delayed union. So 2014 was a year, and then 2018, Indian Stem Cell Study Group Association was born. It's a registered organization having its own ethics committee. And the aim is to take everybody, the clinician, researchers, because this is a science which is, because we are a clinician on one side and the product which we are using is a research part from the scientist. So the aim is to give a perfect inclination to the treatment part by creating and developing the international scientific relation with the rest of the world to elaborate, deepen, and radiate the knowledge acquired in the domain and pass it to all for their opinion and cooperative work. And in fact, to use this branch at a national and international level to do the challenges. Now, we'll request Professor Alok Agrawal for what are the various applications of orthobiologics, as now we are entering into orthobiologics now, specifically to orthobiologics. Over to Professor Alok Agrawal, sir. I'll stop sharing my screen and I'll request Professor Agrawal to please share your screen.
Thank you, Dr. Manish. I'll start with some basic principles that were coming from Dr. Tanmoy Mohanty and gradually go to the actual application of stem cells that we have been doing. So as we all know, stem cells are primitive, unspecialized cells that can self-renew and differentiate into more than 200 types of body cells. It can regenerate deteriorating cells in different parts of the body, such as heart, bones, muscles, and nervous system. It can be obtained from the embryo, the fetus, and the adults. We all know that all of the cells in the body originate from the stem cells. Self-renewing cells with the potential to differentiate are termed as stem cells and are an essential part of the normal growth and development. So what is a totipotent cell? These are cells that can develop into all cell types in the human body and can also form extraembryonic and placental cells. The cells of the early stage of the embryo are the only totipotent cells and are not in clinical use due to ethical concerns. What are pluripotent cells? Cells that can develop into cells of all the three germinal layers: endoderm, ectoderm, or mesoderm. Cells of the late stage of the embryo after the blastocyst stage are pluripotent cells. What are multipotent cells? These are cells that can develop into more than one, but not all germ layers. Adult stem cells and cord blood cells are multipotent cells. So what are the types of stem cells? Embryonic stem cells, that is prenatal. These cells are obtained from the blastocyst stage of the embryo, as we discussed. And because of the properties in them, which can go in any of the lineage, they are also prone to tumor formation. And that is why is the issue of ethical dilemma. Adult stem cells, also called as postnatal stem cells, they are obtained later in the life of the embryonic stage. They are multipotent, undifferentiated cells located among specialized tissues with the primary function of maintenance and repair. Mesenchymal stem cells, which originate from the mesoderm, are a type of adult stem cells that have a good potential to develop into adipocytes, chondrocytes, myoblasts, and osteoblasts. So what are the sources? Well, it is the bone marrow, periosteum, adipose tissue, placenta, umbilical cord, blood, human amniotic fluid, dental pulp, synovial tissue, skin, and skeletal muscles. Bone marrow, adipose tissue, and muscle-derived mesenchymal stem cells are being commonly used practically. So that is it, embryonic from blastocyst, adult from fetus, and from adult. They give multipotent cells, they are difficult to isolate, and they have got a limited lifespan. So you have to do things fast. These cells may be unselected cells obtained from autologous bone marrow after centrifugation, or selected and enhanced in culture utilizing their affinity to tissue plastics. It is a cost involved, time to culture, risk of infection, loss of function in vitro, which prevent regular clinical use of cultured mesenchymal stem cells. It should be noted that the absolute number and the purity of cells obtained from cultures is higher, an important factor for clinical effect. Bone marrow is taken from the posterior iliac crest, and it gives a higher yield of mesenchymal stem cells compared to the anterior iliac crest for bone marrow aspirate. And multiple studies have emphasized this fact. The routes of administration are: they can be applied directly to the lesion by surgery, or by local injection, or by a suitable scaffold or carrier. Mesenchymal stem cells can be taken through initial phases of differentiation, forming bone or cartilage precursors under laboratory conditions, and then implanted into lesions. Mesenchymal stem cells can also be injected intravenously. This ability to migrate systemically and colonize the bone marrow after peripheral injection is being utilized for treatment of osteogenesis imperfecta. So these are the different uses, where you can see that the bone marrow can be used for osteoarthritis, rheumatoid arthritis, articular cartilage repair, meniscal repair, fractures and non-unions, osteonecrosis of the femoral head, and to stimulate growth in children with osteogenesis imperfecta. Periosteum is used for healing non-union of distal third femur. Muscle tissue and bone marrow can be used for Duchenne muscular dystrophy, and in general they are used for improving tissue regeneration in musculoskeletal disease such as osteoarthritis. Coming to the orthopedic applications, well, autologous bone marrow transplantation in patients with subacute and chronic spinal cord injury has shown good results. It has also been found that propofol, an anesthetic agent, promotes spinal cord injury repair by bone marrow mesenchymal stem cell transplantation. The chondrogenic differentiation of human bone marrow stem cells in transfer cultures has given a generation of scaffold-free cartilage, which is routinely used in osteoarthritis. Generating cartilage repair from pluripotent cells has been tried out also in osteochondral lesions, osteochondritis dissecans, and lateral lesions. Autologous bone marrow aspiration concentrate has been found to be safe and useful, and this aspirate concentrate is somewhat different from using osteoblasts. So coming to orthopedic applications of stem cells, well, they can be used for fractures, bone defects, and non-union. They can go for ligament tendon injuries like rotator cuff lesions, anterior cruciate ligament injury, medial collateral ligament, Achilles tendon ruptures. They can go for cartilage defect and cartilage repair, even in early stages of osteoarthritis. In the spine, they can go for spinal trauma, spinal cord regeneration, and disc degeneration, while they are also used for muscular dystrophies and osteogenesis imperfecta. We have been using them for osteonecrosis of the femoral head. And this is very common in your area, especially after COVID, but also because we are staying in a sickle cell avian belt. We have been using autologous cultured osteoblast concentrates for osteonecrosis. Well, osteonecrosis of the femoral head was first described by Monroe, 1738. The causes are varied. Primarily affects the active population. And the management by them is used based on the staging, 1 and 2, extent of the lesion, location of the lesion, cause of the lesion, but usually we do it when the head is remaining spherical. If the head has got damaged, it has got depressed, if it has gone arthritic, then maybe they are not very good for osteonecrosis of the femoral head. And the goal is to diagnose it in early stages and prevent and delay further progression. So as I told you, modified Pickett and Arlett stage 1 and 2. 20 ml of bone marrow is aspirated from the posterior iliac crest. It is sent for live culture osteoblasts. So that is, you can see it is being aspirated. It is being taken in a special container where it doesn't clot. We take 4 ml of the bone marrow from each iliac crest, so the chances of having stem cells becomes more, and it is not only dilute bone marrow. And then you move it so that it doesn't get clotted. It is centrifuged, and then it is labeled properly, put in a special container, and then sent from our center to the lab that is in Pune, where it will be taken care of aseptically, cultured, and then they give us back a concentration of 48 million osteoblasts for implantation. The mean age of our patients for 25 years. Mostly they were sickle cell patients. 7 were male, 3 were female. It takes usually 3 to 4 weeks of the culture when we get a phone call. And that is the time when we get the time we put the cases, and it has to be very fast. If we delay the procedure, the cells will die. Fibrin glue is used for delivery and to see that it doesn't trickle off. So guide wire is passed at the avascular zone. You go for core decompression with 8 mm drill guide. You take curved curates and curate out the avascular bone. And believe it, the dead bone is so hard, it is very difficult to take it out. But then the vascularized bone bleeds, and you get to know that now it is the soft bone which is bleeding, and our work is done. So you take away all the aspirate and you dry the field by injecting air. You pass a screw so that the needle goes in the center, and then you slowly start to deliver the osteoblasts, and you wait for the jelly to form. It takes around 5 to 6 minutes, and gradually the jelly comes back, and we keep on taking out the needle, and finally we take out the screw and lock it with the bone plug, which we get from Tata Memorial Hospital, Mumbai. So here is a case, Lokesh Chaddha, 25 years, and you can see he's having bilateral avascular necrosis, and the procedure has been done on him. This is the immediate post-op X-ray. You can see the course nicely. Usually for 3 weeks, we don't permit the patient to bear weight, and that is the time when the patient comes to us, he is not having pain. This is the X-ray of 1 month post-op, and there have been more months, and the patient is walking comfortably. Another patient, Priyanka Darshan, a 32-year female. You can see one side the head is totally avascular and it is depressed. Maybe this is not a good one, but the other side, stage 3 avian, is there. But the procedure was tried out. One side we went for a total hip replacement. On the other side, in the same sitting, we went for a core decompression. And post-op now, the lady doesn't have pain on either side. The avascular hip side where we have done this osteoblast transfer is giving good range of motion, and she is very happy. Yet another case, Riya Sahu, 24-year-old female. You can see the X-ray with avian on both the sides, and bilateral core decompression has been done. And that is a 1 month follow-up. both AP and lateral views. The beauty is that you can see that the head is healing. At the end of healing, you don't see the track at all. And here you can see that even at 1 month, it is very difficult to say that the procedure has been done. The scars are very small. The patients are very comfortable and they are happy. And this thing has been more rewarding in cases of sickle cell disease. So we have got a solution to save our hips of sickle cell disease. So that is the use that we have been doing. And these are the principles for use. Thank you.
Thank you so much, Professor Alok, for enlightening evidence-based talk on orthobiologics, especially the avian part. And yes, we do agree that sickle cell is a great problem, and that is very much common at the belt around the Raipur. So there are so many cases with the sickle cell, and after the COVID, yes, definitely, there are a lot of cases, increase of the cases, sorry, for the avian head of the femur. So we have seen that lot of indications are there in orthopedic subject. Now over to my talk. So in next 10 minutes of time, I'll take you to those areas which we do in a regular way, we manage in regular way, and we don't know till now or a decade back that they work very well because of the stem cell therapy. We orthopedic surgeon, we find all the results in many treatment plan because of the stem cell which are there in the body. And that is the beauty of the interventional orthobiologics. So I always insist that interventional orthobiologic has got a lot of positive role in the orthopedic condition, and we can use it for the need of the patient. Interventionally means you can use PRP, you can use bone marrow cocktail, you can use MSCs, even you can use a MSC from adipose tissue, but it is in the area of the restriction as by the laws of ICMRs. So definitely minimal manipulation has to be done, and that is the PRP and or the BMAC with the clinical trials on, with the consent and proper work to be taken care of for the clinical needs of the patient for the stages of the diseases. Let's see the fracture healing. If a patient is coming for a non-union, delayed union, then what to be done? So definitely in that case, we can use the interventional orthobiologics. And we see a lot of cases of delayed union, non-union, and that is all because of the lack of the active population of the stem cells. Rather, stem cell is a misnomer. It should be a progenitor cells at that particular location, which are less in number, less in activity. Similarly, self-limiting condition like RA, we've seen many times that a patient of rheumatoid arthritis comes and they get resolved by the time, because they are again the T cell immunity, they take care of it. So again, the stem cell has got a role, a self-limiting role. Even a electrical stimulation post injuries in the nerve, help in the nerve growth, which we see in our physiotherapy department to be used. I'm not discussing about the post-spinal cord recovery, but definitely it again works on the principles of the stem cells. In the sports injury, nowadays, definitely we have a lot of modalities because of the arthroscopy for the last 2 decades, for which the ACL and PCL reconstruction, a lot of things can be done. But remember, before that also, a lot of ACL partial tear healed, because we used to ask the patient for doing a wonderful quadriceps hamstring exercises, because they are again recruiting the stem cells at that particular site, which are there in the body, to perform their action. So the results were again those good. So actually for this, we can say the mechanism is because whenever we do a knee exercise, means whenever we do a hamstrings or a quadriceps, then basically we are activating endogenous stem cell pool at the insertion site of the tendons and the ligaments. Here is insertion site of the ACL at the tibial attachment, at the femoral attachment. So by exercising, basically we are stressing out at that particular point, and at that interface, regeneration of the ligament, that particular ligament occurs because of the activation of the endogenous cells. So this is there. The stem cell technology was been there, but we are not able to correlate it. But now we are able to correlate it, that it works very well. And this is the way it works very well. So those unanswered, those gray areas which were there in our mind can be communicated very well, that how it works, how it heals. Similarly, the bone healing is very much faster in the children's. That is why we are very happy, managing pediatric fractures conservatively most of the time, because whenever there is you can say rather, the children in their blood, they have 10 times more stem cells per milliliter of the bone marrow. So they have got 10 times more than adults. So such a vast number of the stem cells, if they are there in the blood, so definitely they are going to reach to the particular site of the trauma, and the healing would be faster. If you remember the basics about the cascade of the events which we have studied about the fracture healing, fracture union, then let us go to a little bit of exposure to the microscopic level, what it works, truly speaking. So whenever there is a fracture, whenever there is a bony injury or any insult, so the platelet at that particular time, they release the factors, growth factors, PGF, for example, which is very important here, which sends the signals to the bone marrow to mobilize the blast cells from the bone marrow. So this is the mobilization part. This is a signal created and that mobilization has been done. Now these blast cells, they are then mobilized to the site of the injury. This is transendothelial migration, traffic to the site of the injury. And when they reach to the site of the injury, then two things happen. First of all, these cells have been there. And secondly, some cells are already been there endogenously, endogenous progenitor cells. So those endogenous progenitor cells, which are already been there, they become active. And thus the differentiation of osteoblasts occur and we see a union. So this is a gray area which was been there, which is now exposed. This is how it works, truly speaking. So this is the entire cascade which has been given in this presentation. But definitely, yes, what the fracture treatment we do by internal fixation or by external immobilization, ultimately the progenitor cells at that particular sites are going to do the job. And in old age, since the cells are less, so we face a lot of challenges in the union process. Sorry. Now, beside this factor, there is one more thing that is called as GCSF. It has been released by the endothelial injury at a particular site. This again do the mobilization of the bone marrow stem cells to the bloodstream, to the fracture site. So these two things, they do a lot of good job. So that means whatever the delayed union, non-union which we are seeing these days, it is basically inactive endogenous pool of stem cell at that particular site. And definitely age of the person and many other factors are been there. And age is the principle. A patient coming with a humeral shaft fracture, which we do internal fixation, wonderful internal fixation, and even then it's not going to unite. So again, the age is the factor. Diabetic, if the patient is a factor, there's so many things which are the different factor, which is out of the subject to discuss right out here, but it works in that way. So positive biomechanical role in orthopedics, yes, and it has been very well proven by flow cytometry that abnormal stress at a delayed union site can be modified with a compressive stress to the cell. That means we are using this treatment since decades back in the form of PTB cast. Nowadays, nobody gave a PTB cast, but when we are doing the PG, at that time, we were giving the PTB cast. So again, we are providing a delayed, making a delayed union to a union properly by asking patient to walk on the PTB cast, because again, they're the compressive forces which passes through the fracture site. They make these inactive progenitor cells to become active, and that has been proved by flow cytometry. Not only this, even a fixator, if we put a Elizaro fixator, any fixator, and we feel that the patient is not able to get a good union, we ask the patient to walk. So the principles are the same, only the answer has been very well given. Well, yes, external fixator, like I've just mentioned, I've done my MS in 98. So at that time, from 99, I was managing a lot of clubfoot, and there were a lot of good, there are a lot of good things which we come across while managing these cases. Any relapsed clubfoot, neglected clubfoot by Elizaro method, by external fixator method, whenever we do a ligamentotaxis, it actually have a osteogenesis, histiogenesis. with the distraction phase on. And one can compare here in both the X-rays. Here we can see this is a pre-case in which the talus is almost fused, and it require arthodiastasis, which is being given here. And to the surprise, some portion of the articular cartilage, only some portion of articular cartilage is able to regenerate, because that is the portion which is not being tortured, not being grossly damaged. So it regain its shape. So these are the things which been, making us to think that it works, truly speaking. When we go back to the papers in 2002, it was been published, very well published, that cartilage regeneration in osteoarthritic ankle can be done by joint distraction. But it does not mean that you're going to distract an osteoarthritic knee joint to give a cartilage regeneration. Because again, it was been pointed out in 2011 by Ligno et al. That osteoarthritic ankle joint have definitely got a cartilage regeneration, provided a joint loading activity has been there, because then the signal pathways are being created. So probable mechanisms, whenever we do a distraction, then definitely endogenous stem cells along the synovium, along the periosteum, along the subarticular space, because periosteum, we all know, we see acute osteomyelitis, and we see a newborn formation. It's again because in the lowermost layer of the periosteum, there are a lot of stem cells, the progenitor cells are there, so they do the job. So definitely, yes, the things work, but only in those cases if the weight bearing is to be done. But does not mean that we are asking the patient to weight bear on a osteoarthritic knee joint and doing a distraction and then going for replacing a HT or arthroplasty. It does not mean that. The theory of the regeneration, which was being put forward in 2013, was whenever a negative pressure has been there in any distraction joint, then the cartilage regeneration has been there. It is just like a negative pressure on the wound healing as we use the skin. There are some theories which was been given, like transcription, co-activator, yes, associated proteins. They are the mediators which are as a mechanotransduction, which play a role in the cartilage regeneration. But that is only been possible if we are going to do a weight bearing, not before that. So lack of cyclic compression on a cartilage is not going to have any effect actually, and only effect will be there if the anabolic effect will be there, if mechanotransduction would be done. And that is why whenever we put Elizaro, all the things, limb lengthening, most of the time we require a weight bearing. As soon as you make the patient to be on weight bearing, the results are very good. So this also means that a brisk walking, whenever we do a brisk walking, our teachers used to say a brisk walking in early arthritis is a wonderful thing. Why? Because again, here we are creating atmosphere to have a cyclic compression, and progenitor cells will become active. And there is a proof, actually speaking, in if you do a patient pre and post, then you can see the thickness of the articular cartilage can be worked up very well. According to the latest research, even the continuous active movement of a joint injury, after surgery or after any articular of an injury or after any damage to a joint, it has got a propagating role on the articular cartilage. To not a complete extent, but yes, this is probable again a mechanism of differentiation of endogenous mesenchymal stem cells, and they work with the restoration of synovial fluid transport. That is why by doing active exercises has got a positive role. That is the reason, not only around a knee surgery, it's only because of the quadriceps we want to go for exercises, but also for a healthy joint, because of a positive synovial fluid transport would be there. Now, again, if I'm talking about the club foot, we must know whatever we are doing in the club foot, whatever the Ponseti technique we are doing it, we are doing a tenotomy, we are doing a ligamentotexus, or even a gradual dorsiflexion in a CTV cast gradually. It has got again a role connection with the regenerative orthopedics. Because the stretching, whenever we are doing a stretching, it is simply like, as I've mentioned already, in a tenotomy. When we do a tenotomy, actually, basically, we are doing a partial tenotomy and just doing a passive dorsiflexion. So here, again, it is stimulating, stretching the tendon at that particular area, and it boosts the tendon regeneration. because the tenogenic properties of the tendon resident stem cell, they start acting, and that is why we found a result. So everything which we do has got a connection with what the regenerative orthopedics is all about. Similarly, mechanical stimulation, if given to a tendon tissue, result in induction of stimulation to differentiation of the tendon, and that is the reason which we see, tendinogenesis in any of the surgery which is done around the ankle with the deformity correction. And similar is the work for the bone lengthening principle also with the distraction osteogenesis, because here again, when we are distracting, we are stimulating the underlying periosteum, the innermost layer, and it's do the job. So the job is to basically stimulate them to make the pre-osteoblast to convert into osteoblast. So there are a number of identifiable, non-identifiable opportunities, the stem cell therapy in the orthopedics, and next coming few webinars, we're going to take one by one, each and everything. But only thing is we have to open our mind. We have to see how this specialty is being developed and is going to take us forward. Thank you so much for a very patient hearing. And now I'll request our next speaker, Dr. Madhan Jeyaraman, for what and how the growth factors have an influence in the regenerative orthopedics. I'll stop sharing now, and I'll request Dr. Madhan to please. Meanwhile, I'll welcome Professor D.P. Bhushan sir also. He has joined here. Welcome, Dr. Bhushan sir. Over to Dr. Madhan. Dr. Madhan,
Yes,
are
sir.
you here?
Yes, sir. Yes, sir. Yes, sir. Very good evening. Myself, Dr. Madhan Jeyaraman. I'm here to present on the topic convivial growth factors in orthopedics. If the past speakers, three speakers, elaborated the details of stem cells and the importance of stem cells in orthopedics in various clinical conditions. And the main important thing to induce the stem cell is growth factor. So let me take you around the growth factors. So what currently Industry 5.0 tells? 5.0 tells in the terms of personalization and only personalized medicine. That means we are directing towards the medical treatment towards a human-centered, personalized one. It is personalized to each and every individual in the community. That is what Industry 5.0 tells. This Industry 5.0 starts with 2020 and it goes up to 2050. So the argument comes whether there is a regeneration or replacement. Yes, regeneration is possible, and the technologies have been evolved from past 2 decades. So what is tissue engineering? It is nothing but a new strategy as both in vivo or in vitro, regeneration of osteocartilaginous tissue along with stem cells, scaffolds, and micromolecules. These micromolecules are nothing but growth factors. So this combination restores the tissue function and maintains the tissue homeostasis by improving the biomechanical strength of the tissues. So what are the bases of tissue engineering? One is scaffold, the second one is growth factor, and the third one is stem cells. So what is this picture indicates? The cells which is studded with scaffolds, the cross-linked fibers are nothing but scaffolds, along with the growth factors, which will give you a regenerate. That is called a engineered tissue, or either it can be a cartilage or a bone or a muscle or a nerve. So in orthopedics per se, we have a few products which will give you a lot of growth factors. The first product, regenerative product, is platelet-rich plasma. This is nothing but a novel orthobiologic with an osteoinductive and osteoconductive property, which acts as a natural scaffold. This platelet-rich plasma acts as a scaffold as well as it releases robust growth factors at the site of action. So this is how we prepare platelet-rich plasma. And while doing a histopathology, we can see, in the peripheral smear, we can see a 94% of platelets in PRP. So how does platelet-rich plasma work? It works via growth factors. There are n number of growth factors which resides inside alpha granules. Once platelet-rich plasma is activated by any means, either by mechanical means or calcium chloride, calcium gluconate, any form of calcium or thrombin, it will get activated and alpha granules start degranulating to release growth factors. It releases various pockets of growth factors, out of which these growth factors are very important. The most important growth factor is TGF beta. This TGF beta promotes wound healing and tissue homeostasis along with VEGF, that is vascular endothelial growth factor, which gives neoangiogenesis. The remaining all other growth factors helps in collagen protection, ECM, that is extracellular matrix deposition, and it promotes hyaluronic acid protection in that wound site, any wound. So this PRP contains 4 or 5 mechanism of action. One is hemostasis, immune response, angiogenesis, and anabolism. In this, our growth factors act in immune response. That is, it is antimicrobial in nature and it modulates the inflammation and pain. The second one is angiogenesis. It contains both pro and anti-angiogenic factors, which will be more helpful in critical limb ischemia, avascular necrosis. And the third one is anabolism. The tissue anabolic factor mostly rely upon TGF beta 1, which helps in changes the structure of a tendon and it helps in dermatological procedures. So in this image, I try to tell you that various growth factors act in various levels. That VEGF act in this particular pathway and helps in angiogenesis. And PDGF, TGF beta, and IGF, that is all our growth factors which helps in ECM synthesis to strengthen and give the biomechanical strength of the diseased tissues. So with respect to joint disorders, this PRP, that is, PRP, once it activates, it will degranulate to give a lot of growth factors, helps in each and every site. So I have taken this joint disorder as an example here. This TGF beta 1 helps in cartilage regeneration, that is called chondrogenic factor. And the other growth factors like PDGF, TGF beta, IGF, and FGF fibroblast growth factor 2, which act on the synovial site of the joint and helps in the production of hyaluronic acid. And the other growth factors which acts on the osteoblast to increase the proliferation of osteoblast, collagen deposition, ECM synthesis, and it mainly decreases the osteoclastic function so that osteogenesis will be happening. So in this way, growth factors are very important in terms of regenerative orthopedics. Now come to allogenic PRP. What is allogenic PRP? This is nothing but a plasma lysate. So why we need a lyophilized PRP? The first thing is there are a lot of variability in PRP formulation to get the amount of growth factors. In autologous PRP, we are not estimating any growth factors, how much amount of growth factors is present in autologous PRP to give the desired effect. But in lyophilized PRP, we can quantify the growth factors and we have better antibacterial activity with lyophilized PRP, and a higher concentration could be actually an inhibitory factor. Yet the quality of the PRP and the quantity of growth factor can be determined and it has longer shell life. So one of the experiments done in our lab with normal PRP and activated PRP, the third one is freeze-thawed PRP, that is lyophilized plasma, and PRP, which is mentioned by some other studies. We compared the growth factor levels in each and every method. In that, we found that significant increase in growth factor could be found in PRP by freeze-thaw method, which is evident here. The next, third modality is MSC-derived secretomes. All mesenchymal stromal cells have growth factors, but these secretomes are nothing but soluble factors along with extracellular vesicles of that mesenchymal stromal cells. The soluble factors are nothing but growth factors, cytokines, chemokines, and the enzymes. These all have pro-angiogenic, anti-fibrotic, anti-apoptotic, and anti-inflammatory property. Among all these things, we have one more thing called immunomodulatory and immunoprivilege activity of mesenchymal stromal cells. Various literature have been published on MSC-derived secretomes. Here are some examples. And the last modality is nothing but MSC derived exosomes. Exosomes are nanoparticles which is present in the body, right from our hair to the nails, even saliva, body fluids, every fluid, every part of the body has exosomes. But MSCs, that mesenchymal stromal cells derived exosomes, have higher regenerative potential than other exosomes. These exosomes are nothing but it contains two things. One is immune factor and one is growth factor. Again, the growth factor comes into play. The growth factors derived from MSCs derived exosomes have the highest regeneration potential than other products of regenerative medicine. So a few literature has been published by our own team. Now, what exactly I want to tell you in this picture is growth factor from a zygote. We have got the full adult here, but this adult, any cell from the adult, any cell can be reprogrammed to form a pluripotent stem cell or any particular stem cell. Each stem cell have various growth factors. That is what depicted here. Each growth factor has a different site of differentiation. FGF has ectodermal differentiation, and BMP4, FGF, and WNT pathway have mesoderm, and other pathways. Activin has endoderms. Each and every pathway will take the necessary growth factors and it will form the particular organ of interest or joint of interest. Here, TGF-beta, PDGF1, and insulin-like growth factors go via mesenchymal progenitors, which is more important for an orthopedic surgeon to know, which helps in osteocartilage regeneration. So the other growth factors helps in forming the pancreas or liver or lung or heart, whatever the field of interest is. Now comes the last modality, that is engineered growth factors. Now there is a product called concentrated growth factor, which we can get and we can give to directly to the site of action. These engineered growth factors will be releasing the necessary growth factors in the targeted site in a sustained manner. So constant release of growth factors is there. Growth factors will be there in the particular site to give the tissue regeneration. The same concept here. So once the engineered growth factors is bought, we can add it to the stem cells, either MSCs or iPSC, that is in pluripotent stem cells, or any somatic stem cells. Along with that, any carrier if we add, that will form a tissue engineering product. So that will be delivered to the site of action to form the particular targeted either cartilage or a bone. So this is an example. This is CGF is nothing but concentrated growth factor along with bone marrow mesenchymal stromal cells is being given, and it is examined to form an osteogenic tissue. The second one is collagen is added along with the bone marrow stem cells. The third one is just a concentrated growth factor, and the fourth one modality is only collagen, and the fifth one is nothing has been added here. Here, concentrated growth factor along with bone marrow stem cells have given a better regen rate than collagen with bone marrow stem cells, than concentrated growth factor, than collagen. So always when we combine mesenchymal stromal cells along with the growth factor, it will give a better regen rate. The continuation of the same thing we have seen A, B, C, D, E, that is called modality 1, 2, 3, 4, 5. It is depicted as A, B, C, D, E. This shows CD4 differentiation was found better in bone marrow stem cells along with the concentrated growth factor. So all these products are either concentrated growth factor or allogenic PRP. Everything is coming under one entity called ATMP, that is called Advanced Therapeutic Medicinal Product. This is nothing but it is regulated by CDSCO and ICMR. CDSCO will tell whether it is a drug or not. So it comes under stem cell and cell-based product classification. So once it is categorized as drug, which is derived from processed cells, either we can manipulate minimally or more than minimal manipulation is allowed under the guidelines of ICMR in India. So accordingly, we have classified the products as 3 risk strategies, that is low risk, and high risk. Low risk is nothing but autologous product. Either it can be stem cells or PRP. The second one is lower risk, which contains the allogenic products, that is amniotic membrane, water jelly stem cells, bone grafting, allogenic bone grafts, allogenic cornea, allogenic tendons. All allogenic products will come under lower risk. The third one is the high risk thing is umbilical cord blood, amniotic tissues, which are all the pluripotent stem cells along with the exosomes. These all comes under the higher risk category. So the low risk category doesn't require any much regulatory guidelines, and the lower risk category is regulated under section 361, and the high risk, that is the third category, is regulated under 351 category. So 351 tells that is the lower high risk, that is category 3. This requires the regulation in the terms of drugs or the biological products. And 361 category, this is the allogenic product which requires post-marketing surveillance, whether it is whether the post-marketing product is safe or efficacious in terms of regeneration. So take-home message is this: growth factors act as a novel biological approach in both osseous and cartilaginous regeneration, with various examples being published literature, and it has immunomodulatory, anti-tumorigenic, and immunoprivileged activities. And exosomes are the secretomes of the very novel nanomedicine particles which can deliver to the target site of action with a therapeutic effect, which has to be explored much in the countries such as India. And we should be always adhere to the guidelines of our ICMR and SEDESCO under section 351 and 361 for minimal manipulation or more than minimal manipulation for cell-based therapies. So these are my partnering agents, which will help me in carrying the further research in regenerative orthopedics and orthobiologics. Thank you.
Thank you so much, Dr. Madhan, for a wonderful presentation describing what are the growth factors, how the growth factors work in orthopedics, which is the key importance for the end result that we get. Thank you so much. So welcome Dr. Naveen Thakkar. I think he has joined. He was busy with the conference. So before winding off, we'll like to have end note message from Dr. D.P. Bhushan sir for the take home, and as well as a message from Dr. Naveen Thakkar. Dr. Naveen Thakkar, are you here? Okay, over to Dr. D.P. Bhushan sir. Professor Bhushan sir, are you here?
Yes, I'm here. Am I audible?
Yeah, you're audible. Please go ahead.
Yes, I am also there now.
Yeah, good evening,
Okay.
Dr. Naveen.
Very good evening.
The man with gold.
Sorry, I was in the program there. Just came to the hotel just now.
Hey, Naveen, thank you. You give us the representation of Bappi Lahiri sort of richness of this our institution. Maja aata hai, but anyway, thanks for coming here.
Yes, thank you, sir.
Somehow Atul could not come, though I have invited him personally in Vairok. There is some network issue.
Right.
No, he has joined. He is Dr. Atul Shasu sir has joined.
He
He has
very
given the
shortly
message, a
and
presidential
yes,
message. When there was some network issue, so maybe that has been disconnected.
Yes, the network issues are there. Yeah.
Yeah.
भूषण जी हम दोनों थे शुरुआत में.
Yes.
अरे सर
दोनों थे. अतुल जी जुड़ गए थे. मैं वेन्यू पे था. अतुल जी तो होटल पे थे, इसलिए जुड़ गए
जी को थोड़ा डिले था, हमें पता चल गया कि वो भी आ रहे हैं.
ये तो बहुत बहुत धन्यवाद to Dr. Atul Srivastava, Dr. Ram Chaddha, and Dr. Naveen Thakkar to attend this first subcommittee meeting ever done in this year. And it is all the inspiration and encouragement of all the three of you that we have started as the first. Tomorrow is another meeting, I have heard, of another subcommittee. So first of all, thanks to all the three of you. Then to start with the Chinmay Mohanty, who had done a great job in introducing us to the new world for which most of orthopedic surgeons are not very well known. Then Alok coming with all the pluripotent, totipotent and multipotent cells and its clinical application from the very beginning. This orthobiologic is talking about the orthopedic involvement also in avian and its results. Manish, as ever, the person well worthy of chairman, he talked about everything and he found the orthobiologic implications in our day-to-day activity like illosaros and tendon lengthening and anatomy. With Madhav Jeyaraman, our newer boy, with growth factor and all the new vistas which are opened. We are very thankful to this team which has taken this lead, and we are certain that under the guidance of the President and Secretaries, Presidents and Secretary, we will follow your hints and advices and take it to the right conclusion. Thank you very much.
Thank you so
Thank
much.
you, sir. Thank you.
Thank you so much.
Thank you, sir.
Now I'll request Dr. Naveen Thakkar to give his.
Yes. Sorry, first of all, I sorry, I was there in the program there in the Pondicherry State Conference. I was there on the stage, so I could not join at the same time. But I think that it must be a good program, educational program, and the short summary has been given by Dr. D.P. Bhushan sir, and Dr. Ram Chaddha has, I think, remained present throughout the webinar. So we are thankful to the committee for giving such a good program to the IOA. And we are thankful to the IOA TV team and the Ortho TV team, those who have taken a pain to telecast this.
Yes.
Thank you all. Thank you all.
Definitely. Thank you so much, Dr. Naveen Thakkar. Thank you so much. So friends, we have seen what is the stem cell, what are the uses of stem cell in the medical science and for the orthopedics. We are already playing with the stem cells for last many decades now. The exposure is there and all the clinical challenges from avian to delayed union to cerebral palsy. There are so many conditions which we can use it in our clinical practice. And in coming webinars, we are going to take over each and every aspect to see how it works and well in that particular time. The next webinar, we'll be planning for a graft because we play orthopedic surgeon with a lot of bone grafts. So how the bone graft and orthobiologics are being connected, that is our next aim. So thank you so much, everyone here for joining today evening. Thank you so much and be tuned for the next webinar. Thank you so much. Thanks a lot, sir.
Thank you. Thank you.
Thank you.
Thank you. Namaste. Bhushan साहब,
हाँ,
I think recording बंद किया कि नहीं इस लोगों ने?
बस बंद कर दे रहे हैं.
Recording to be stopped now.
Yes.
अभी चल रहा है, थोड़ा सा चल रहा है, ऊपर दिखा रहा है, ब्लिंक कर रहा है.
और दिख रहा है यानी वो
We will talk
वो
later.
साइड में चले गए हैं, तो we'll talk later. So I am leaving meeting, so sir.
Okay,
Yeah,
right.
fine.
Okay.
Thank you so much.
Okay.
Thank you so much.
Right.
Thank you.